an esteemed member of Maharashtra Ophthalmological Society, and also all the members who are joining us today from even All India Ophthalmological Society and neighboring states as well. Friends, we all know that in the current era, the insurance empanelment has been also a boon and a bane for both the patients as well as for all the medical fraternity. There have been multiple challenges and multiple issues which have been raised, and there are challenges faced again not only by the patients but also by our ophthalmic fraternity, especially. And this special webinar has been organized to sensitize all our members to understand what are the current challenges by some of our esteemed national speakers, and also to find a solution to come on the same grounds at both state and the national level and work together towards achieving a better tomorrow for all of us and also for our patients. So, this special webinar is going to be chaired by none other than our Honorable President, Dr. Santosh Agarwal, sir. Dr. Santosh Agarwal, sir, is the President of Maharashtra Ophthalmological Society and has been a alumnus of Shankar Netralaya. Sir is a leading both entry segment and retina specialist from Aurangabad and has done humongous work also in the field of retinopathy of prematurity. It is Sir's vision this year that we all should do collective work. All the members should always come together and raise ourselves together. So over to our chairman, Dr. President, Dr. Santosh Agarwal sir, to deliver the welcome address. Thank you.
Thank you, Vardhaman. Uh, Respected Nirmal sir, Dr. Hari, and esteemed MOS members. Good evening to one and all. I welcome you all to this very important webinar, which will throw light on the medical insurance issue, which is a very burning issue. I got so many calls from our members that insurance companies are mounting pressure on them to sign the MOU before 31st October. And there are many clauses which are not acceptable to our members. The first one is the tariff, which is very low. Second is we have learned from many members that insurance company as well as IRDA, they are coming out with 100% cashless insurance policy, which create many more problems not only to doctors but also to the patients, because they are not allowed to opt for newer technology, newer lenses, and higher packages. And secondly, the reimbursement also, even if it is done, the tariff is same as that of cashless. So it is also not acceptable. Third is the insurance companies are posing their own rules and regulations upon us, and without taking our association or the health providers into consideration. The grievance cell is also not hearing our voices. So this webinar, as Vardhaman already said, to sensitize our people, we should know what is going on and what will be there in the coming years. So unitedly and with the association like MOS and Tamil Nadu Association, as well as our parent body AIS, IMA, all will come together and we will uh, put forth our grievances and voice in front of IRDA as well as the insurance companies. This is the purpose of this meeting. So I will appeal all the members of MOS to listen to our stalwarts, Dr. Nirmal sir and Dr. Hari, and they can put their questions in the chat box also. Thank you, and over to Dr. Vardhaman.
Thank you very much, sir. And now we are extremely lucky to have both our experts who are definitely experts of national stature when it comes to the insurance related challenges and have done humongous work in insurance related work for our society at both national as well as their own state level. So I'm going to introduce you to both our esteemed speakers. The first one being Professor Dr. Nirmal Frederick sir. Dr. Nirmal Frederick sir has been the chief eye surgeon and the MD of the Nirmal Eye Hospital Private Limited. Sir has been at variety of leadership positions, and sir has been the member of the accreditation committee of NABH, has been newly elected to be the president of the prestigious Tamil Nadu Ophthalmic Association, has been the chairperson of the insurance committee of the IMA of Tamil Nadu, has been the advisor and the editorial board member of Tamil Nadu Journal of Ophthalmology, and has been a executive committee member of Ocular Trauma Society of India. Sir has given more than 1500 lectures until now and has published more than 45 publications. Most importantly, he is the author of the NABH Eye Care Standards and the NABH Guidebook to Eye Care, which is a Bible for all of us when it comes to NABH assessment. He has also written the AIOS book on accreditation of the eye centers. Sir has received more than 30 named awards and orations, including the prestigious TNOA Dr. Joseph Oration, Professor VVR IMA Oration, Dr. Deshpande Oration by Pune Ophthalmic Society, Dr. DL Shukla Award for Outstanding Contribution to National IMA, IMA National President Appreciation Award, AIOS Preeti Natarajan Award for Best Eye Hospital Administrator, so on and so forth. So we are extremely lucky and we are very fortunate to have Dr. Nirmal sir to guide us today regarding the challenges of the insurance related matters. The second speaker that we have is somebody who has done truly a ground level, meticulous, and probably one of the most hardworking people I know when it comes to the insurance related matters is Dr. Hari Krishna from Hyderabad. Dr. Hari Krishna is an alumnus of the prestigious Armed Force Medical College. He has done both his MBBS and ophthalmology residency from there. He is currently based out of Hyderabad and has started his own eye center in the form of Iris Eye Hospitals, which I believe has now gone to 3 centers. He has also started an arm called as Iris Mediworks, which is an offshoot which helps in consultation regarding insurance related matters, regarding the practice management related matters. And he is somebody who has actually managed to marry the science, the art, and the commerce of both ophthalmology as well as the insurance related matters in general. So we are also very honored to have Dr. Hari with us to enlighten us about the insurance related and MOU related matters today. So we would like to start the first talk by Professor Dr. Nirmal Frederick sir about the challenges which are being faced regarding insurance by our societies. Over to you, sir. Thank you.
Thank you, Dr. Vardhaman. Thank you for the elaborate and kind words. And so let me I bring warm greetings from Tamil Nadu Ophthalmic Association to all the new office bearers of MOS. And it's indeed a great pleasure. And thank you for taking this initiative. I think you're one of the few state societies which have been in the forefront of working and fighting for all the matters relevant to medical fraternity. So thank you so much for that. And coming to our webinar, so I'll be talking about the challenges in eye care delivery and how we can confront it through a collective approach. And since Dr. Hari Krishna, who's done a wonderful work with reference to educating our members and also highlighting the various ground level challenges and helping our members is with us today. So he will take care of the small nitty-gritties, and I'll be focusing more on the policy-related issues so that our members understand the perspective in a better way when they understand these challenges. Right. So Vardhaman started with whether healthcare is a boon or bane. So that is for the history to decide. and you all know history is written by the winners. So the greatest discovery comes not from seeing the new landscapes, but in seeing the familiar with new eyes. So we have to see our practice, see our finances, see patient care and the quality of care from a new perspective and see the familiar with the new eyes. Particularly in the context of healthcare insurance, some choices don't really matter. They're already in practice, either started up or midway in the practice, or trying to scale up, or joining hands with few corporate. So some choices don't really matter. We have to continue in practice. And we all know about this policy statement, subject matter of solicitation. So basically, insurance is buying a promise. Is that promise is being kept? So there are so many key stakeholders. So before really going into how we are going to face the challenges, we have to see who are all the stakeholders in this aspect. So healthcare industry is a major industry of our country, and insurance is another major segment of our country. And insurance has brought health insurance to the country. So all these are stakeholders, right? From patients to providers, that means us. And as we progress in medicine and practice of medicine, previously it was two-way contract between healthcare providers or doctors and the patients. So always it's better to deal with directly. The moment more parties come in between, so whatever happens in our family matters, same happened here also. So when the government intervened, and when the regulator came in, and the insurance companies came in a big way, particularly after the foreign direct investment, many private insurance companies came into the picture. And then that created a vast network of distribution channel partners, TPAs. And the moment all these companies came, the media intervened and a lot of NGOs. So the whole system became very complex. So the basic elements in health insurance framework is the three major players: the insurers, providers, and the community or patient. So in between there is what is called as risk management, and then the administration part. So insurance has to be administered, and between us, the provider, and the patients or community, there has to be a quality framework. So it's not as simple as this diagram, but there is also a complexity added here. So in between the insurance companies and hospital, there is one third party. So basically, administrative framework. And we all know there are many systems, and government is pushing for universal coverage. And so government and government supported social schemes are already there. And in the private insurance, so there is PSU companies. We all know them as GIPSA companies. That is the major share, but now their share is coming down. So previously they were almost 90%. Now they are down to somewhere 48% post-COVID. The private insurance, thanks to the government policy, is taking upper hand now. So this between PSU and private insurance, the percentage is changing. Then there are group insurances and retail schemes. Right. So before going to that, we have to understand the economics, healthcare economics, and how it relates to the quality. So basically, I'm a quality professional. And when we look at healthcare policies from quality perspectives, we have to understand the economics also. As I said already, when there is nobody between doctors and patient, the transaction was easy. Either it is barter system or direct payment of money between buyer and seller. So the buyer valued the product and service more than the money, and buyer checked the quality by word of mouth, or there was some local feedback. And the seller, that is the doctor and the hospitals, valued the service more than the money he received. So this ensured best quality for appropriate or minimum price. So that is how our healthcare cost was under check. Basically, due to the magnanimity of the providers and doctors, as well as the moral structure of our healthcare framework. The second level of payment is the second party transaction. So somebody pays for the patient. It may be a daughter, son, or so nowadays the companies pays for its employees or its employer relatives. So here buyer doesn't have to use the service or product he buys, right? But has to pay for it. So that is where problem comes in. So most of the corporate health policies, when the corporates are really belligerent, they would demand everything. So they doesn't care about quality. What they want is more of quantity. So and want to pay less. Then the third step or third type of economic is where the buyer doesn't have to use the product he buys, nor he has to pay for it. So this is the typical government system. The government and particularly the Babus and Netas do not use the service they buy for the people. And the payment is not done with their money, it is with the taxpayers' money. So there is no quality, only quantity. By definition, all these kind of third-party systems are bound to fail in the long run, or they may not produce the desired outcomes. So we have a complex system. So we all know that as doctors, we are the basic structure or pillar of healthcare service provision. But now we are somewhere in this maze. And insurers trying to take upper hand with the support of other stakeholders, and patient is a bit clueless. So what is the challenge? So these are the challenges. So there is a lot of not only challenges, there is complexity and therefore confusion. We have to understand the framework of government schemes. I will not go into the details, but just highlight how all this evolved and why this 100% cashless is coming into the picture. You all know government initiative, they wanted to care for their ex-servicemen and government employees. So they gave something to the healthcare providers like land or tax exemption, and then demanded certain provisions like 10% rent or better care for the ECHS. So our people, since the ex-servicemen were working for us, for our country, they gave a lot of support. So they adopted the lowest rate possible to the CGHS scheme and ECHS scheme, as well as some social schemes like ESI and the state government schemes. And this was implemented in a slow manner and then extended to 26 states. So this is how it evolved from ESI in 1948, Provident Fund 52, then RSBY, and now Ayushman Bharat. So when technology came in, it got integrated. There was huge data that was collected as part of Ayushman Bharat, and NHA, the National Health Authority, had huge data, and with that they started building the new health policy. And of course, state governments had their own schemes. So in Tamil Nadu, it is CM scheme, and in Hyderabad, Aragyashri. There are various state schemes, and this is given by both government hospitals and private healthcare providers. So this is a new study by Lancet about healthcare policy on the health financing perspective. So you have to understand this background of cashless before really wanting to join with them or fighting with the issue. So this is the status, the data that is coming in. So you see the 40 to 50% of utilization happens with the government hospital. So entire funding, 50% goes to government hospital. And other than that, there is administrative cost of the huge insurance network and the TPAs. And the private part is negligible and limited to certain medical colleges and NGO hospitals. So here the private share in the primary care and secondary care is less. If you see the top states there, Madhya Pradesh, Tamil Nadu, and a few other states. And but over a period of time, the rates were stagnant. We all know how CGHS defaulted on payments, crores of payment to hospitals. And what started as a social scheme with a noble gesture proceeded with lower consultation fees and procedure rates. And it was basically a failure because no hospital is willing to provide the service at that pathetic rate, but it is being forced. Now, this is the present status. So, pathways to reimagining health insurance in India. This is again a white paper. So, the top 5 challenges. So, tough statutory compliances for the private hospital, unrealistic expectation of patients, financially non-viable rates because of rising cost of healthcare delivery, and exclusion from the public funded healthcare insurance scheme. So most of the private enterprises are being excluded in a phased manner because of the difficult empanelment criteria or the low rates and difficult sustainability, and lack of any support from the government with reference to policies or governance. And you also have to understand what exactly is GIPSA. GIPSA is nothing but a group of public sector insurance companies, and it's acronym for the General Insurance Public Sector Association. And so this is the number you have to know. So in the government schemes or the entire health insurance, 58% of hospitals and are private. So which means 60% of the care is provided by the private sectors. And this is the strength in urban areas, 70% bed strength is by private providers, rural areas 63%, and among the doctors 80% are private people. So basically the private entrepreneurs, the hospitals and healthcare providers have to understand this. They don't know their true power. If they unite, so we can basically fight or in fact get good policies to favor our private healthcare providers. And this is the status worldwide. The private health insurance companies always act in a big boss manner, and the premium increases are outrageous, but the payment to the healthcare providers are pathetic. And in the process, the entire framework, the public, the providers, everybody suffers. Right. So these are the background. So what happens? So is cashless going to be real cashless, or it's going to be a careless policy? So what do the ICs and TPAs say about the healthcare system? So this battle has been going on for some time, conflict between insurers, TPAs and healthcare providers. And these were the issues. And the cost inflation. So as accepted by them, medical cost inflation is around 20%, which means every year the cost of providing services goes up by 20%. And you know the background that the last 7 to 8 years, there was no revision in the packages nor the reimbursement rate. So there lies the problem. And these are certain judgments. Maybe Deshpande sir can highlight some of this. TPAs are only facilitators and can't reject mediclaims. So our people have to understand. I think Hari will focus more on this. So TPAs are basically administrative people. They can't take the decision. So you need not be really scared about what the TPA is writing or sending mails. So you can literally fight if you have a good MOU. That's where people like Hari comes into the picture. So you have to really go through the MOU document diligently and have to work for it. So this is the basic. So health insurers have been successful at two things: making money and getting the public to believe they are essential. So this is what happened in our political and governance framework. So the health insurers has contributed nothing related to patient safety and value to the healthcare system. But in the process, they've increased the complexity of providing healthcare service. They've raised the healthcare cost because of the administrative hassles and additional middlemen. And they've created an entitled class of administrators. If you see the emails and all the communication from the TPAs and the ICs, you will understand the strong wordings towards the healthcare providers, and particularly many of their queries are really absurd and the language is really pathetic. So basically, they are thriving at the cost of healthcare providers. So you know what to call them. So most of these are parasites or tumors, and they have to be treated that way. So how do we proceed now? And what has been our response? So our response has not been that good. So basically, if we are, so this is a survey in IJMS, Indian Journal of Medical Sciences. Almost 75% of healthcare providers have experienced these absurd queries, asking for more clarifications, and another only 1% didn't receive any queries or this claim rejections or deductions. So which means 99% of us are really suffering from this. And reimbursement rate. So previously reimbursement was available. Now they are taking this facility, which means you have to depend on insurance for patient payment. And there's a huge administrative burden. The moment you get insurance patient, we have to get at least 5 documents and 10 to 20 pages of reports, and you have to send them e-copies, soft copies, and then courier. So all this adds to the complexity, manpower, as well as documenting this. And then there are huge unpaid bills, a lot of high deductibles that happens after they sanction, and co-pays that is very difficult to get from our patients. And the flexibility is not there because so we have to depend on their approvals to provide care. So this actually frustrates our healthcare providers and adds to the stress. And there have been a lot of claims by the insurance companies that there is greater choice of hospital. But you all know many of our small eye care providers are really waiting for a long time for empanelment. And they say efficiency is through competition, but this competition only in cost, not in the quality. And in cost control with packages at the cost of quality. And they say there is more transparency, but they expect this only from the providers, right? The moment we ask them about how they have costed and how they arrive at the packages, there's no answer from them. And quality control only from the providers, not from the TPAs or the insurers. So basically, all these issues are really giving not rest, but unrest. So increase in cost, and more importantly, it has damaged the doctor-patient relationship in a big way. If you see, most of our problem with patients, negative feedback starts because of the insurance, starts at the insurance desk or because of the insurance cases. So these are some of the key issues. So insurance is not addressing the fundamental problems of healthcare, that is cost, choice, access, and quality. And that is affecting everyone, the uninsured, the underinsured, and everyone else who is insecurely insured. The moment you have a Mediclaim, you don't know whether they will honor it or not. So how can we work together to solve the issues as providers, as collaborators and stakeholders, and as association to help our members? So what should our hospitals do? Our hospital has to understand the framework first. So understand the insurance system. And if you have insurance desk, it's our duty to train them with hospital insurance policies and procedure. Whether we have SOP for providing the service or not, we need to have standard operating procedure for insurance related policies and procedure. How to draft a MOU, how to send the email to them, how to reply to them. So all this framework has to be part of the SOP. And negotiating better reimbursement rate as well as cashless rates. Hari will take this up. Managing patient volumes, and there are certain alternatives that we have to try as a group. And this is the reality now. Post-COVID, if you see, the health retail has increased by 44.25% in the standalone health insurers. And this is why they have become so belligerent. A huge growth of 44.25%. And if you see, all other insurance have come down. The motor or the general insurance have not grown. Only the health insurance grown thanks to COVID. So this is the reason why the conflict has increased. And if you see the outpatient expenditure and inpatient expenditure, it has tremendously increased. So the huge increase in medical cost as well has really contributed to the growth of the healthcare, both retail as well as group healthcare insurance. And we also need to teach our people, our doctors particularly, and the insurance desk about the principles of certain insurance. I'm sure Hari will go through this, but I'll just highlight few things. So insurers basically, there is a principle of indemnity that you must not make a profit from insurance, right? But doesn't mean that we should not be sustainable. Self-sustainability is very, very important for any business. And principle of contribution, if there are two or more health provision to the patient, there will be shared compensation. And principle of subrogation, laws of minimization, principle of causa proxima, all these are not related to health insurance in a big way, mostly related to the motor and life insurance. So, but unfortunately, many of the health insurers bring all these principles to healthcare. So this is where there is complexity in the system. And a lot of key terms you have to understand, particularly copay, the daycare procedure concept, the OPD charges. Even recently, AOS has sent a mailer to all our eye care providers to differentiate between OPD procedures and daycare admission procedures. I'm sure all of you would have gone through it, but if not, please go through the mail and please follow that. There are a lot of other things, free look period, waiting period. I am sure Hari will go through this. And these are some of the terminologies we have to understand before really working with the insurance companies. So this is one aspect we have to understand. Sum insured in health insurance. Of late, the sum insured is really going up. Previously, it was only 3 to 5 lakh insurance. Now, with the advent of COVID, as well as the improvement in economy and the group policies, the sum insured has increased to average of 20 to 25 lakhs, which means when our patients are packed into lowest package rates, irrespective of the sum insured, the insurance companies will pay only this particular amount. So that actually is not good for the providers and definitely not good for the patients, because they are going to get the same care irrespective of the amount or premium they pay. So this have to be highlighted to all our patients. So that is our suggestions, that the payment has to be in proportion to the sum insured. So we also have to work on all these things. So challenges, pre-auth related queries and repeated auto-generated mails, requests for discount at all stages. This is what IMA and all other associations are fighting now. And of course, tariff rates and pathetic packages. And reimbursement has to be retained. And these unfair reductions and reduction, we have to fight at all costs. And the special discount at any stage, please do not agree for any discount once you sign a MOU. So this is very, very important. At any stage, please don't sign or agree for any reduction or reduction. And this is one adjudication for the IOL. So there are a lot of queries in WhatsApp groups about the billing system. So IOL better to be billed under separate head. This is a requirement, particularly post GST and to the improve our costings. So what should our hospitals do? Work on their scientific costing. What you have to understand what cost you incur to provide that service. That includes manpower, that includes equipment, as well as your chat time and your staff expertise and experience. And improve the documentation administrative efficiency and adopt technology solutions. So technology over a period of time can give good return on investment. And basically join any group effort to leverage our collective bargaining power. So how can we do that? So I will not go into this, but how, and better to have an insurance desk with all the signages and tackling the third party. Hari will cover this, and also understand the regulatory provisions. If TPA or insurers are not paying you within 30 days, but so you have to escalate the issue to the grievance mechanism, and they are bound to give interest as well. Particularly if you are MSME, please use that provision and get the. So once you do this for 2 or 3 times with the TPA or insurer, they will definitely oblige you as well as follow it diligently. So I raised it for at least 3 or 4 times with the insurance companies on the payment issue. Now almost 90% of my payment comes within 15 days. So this is a template we have sent from, and we also request our patient to send this email. So this is a template. Maybe I can share with the Mos team. So this template, I give it to the patient and ask them to write to the insurance companies and TPS if there is a delayed payment or reduction in the payment. So the moment the patient is involved, particularly if it's a corporate client, the ICs and TPS oblige. So TPS is here to stay because outsourcing is always cheaper for the ICs, and ICs can claim settlement payments directly to the consumers. We are also asking them to go for this direct settlement. And role of associations. So the last few slides. Advocate for fair insurance policies. We have to work at the advocacy level. We are with the government as well as the General Insurance Council and IRDA that the healthcare insurance framework should benefit all the stakeholders and it should not be one-sided. So we have to use our power to lobby for changes in the insurance regulations to improve payment as well as retain reimbursement policies. And on the association front, we have to provide education and training on all these key aspects to our members. I see a lot of queries in the WhatsApp group, most of them related to very poor understanding of the insurance process and the framework. And we also need to share information, so regular information from the leadership. And we also have to give some formats and templates for standardization. And if there are any issues, we have to mediate between the hospitals and the insurance companies in resolving payment disputes. So they will oblige a larger association than individual providers. And so there are a lot of empanelment issues, a lot of corruption and nepotism with this. So we have to work as a group to ensure that all our hospitals are empaneled. So this is very important to remove this. So these are the problem: no response, delayed response, middlemen, and corruption. And this certification should not be a mandatory clause, but of course it should be incentivized by higher packages. And this is the legal system. All registered and eligible hospitals have equal rights to get empaneled. So we see a lot of real pressure from our members, and also they go out of the way to get empaneled. So it is your right. Please ensure your rights are honored. And this Rohini registration is the additional requirement. We are fighting for only one single registration, and that should be the single point for all empanelment. And for empanelment, they have made package rates as mandatory. We have asked this clause to be modified and removed. And of course, remove all middlemen and corruption. Don't encourage corruption in insurance. It is your money. You are giving the service. You are entitled to your fair compensation. And this is one thing that is about the cashless for government schemes. So government has taken upper hand and pushed only cashless. But this is the Madras High Court judgment which was pronounced on 2019 that reimbursement claims of employees and pensioners is their right, and state health schemes not charity. So you can quote this if you really want to go overboard and help your patients. Package rate, never quote below the accepted and approved rates. So we have given, we made a TNOA insurance committee and arrived at some common packages for the corporate limits and non-corporate limits. And our request to all the members is to quote these rates and never to underquote or never to accept lower rates, and accept all the packages what you are doing and never quote for packages or procedures that you are not doing. This is very important for our unity as well as growth. And how do we address the costing? Please understand, anywhere in any business, terms of lending is decided by the lender. Only in health insurance, the terms are decided by the debtor or the insurers or TPS. So this is the biggest hurdle, and we have to reverse this at any cost. And so once you do this unreasonable pricing demands from insurance companies and unilateral decisions will stop. So we need to address this anomaly. And these are some of the associations which have taken great initiatives to streamline the rates. And this is the letter we have written to IRDA about all our problems. maybe Mos and other state associations can follow. If there is, if this same letter goes to the IRDA and the GIC, they know that we are all united as healthcare providers across the country. So SPD resolution and on-table discussion we can expect. And this is a letter we have sent to all the insurance companies highlighting the problem faced by eye care service providers. And this is one insurance summit where we gave 5 demands to the ministry as well as the GIC and all the stakeholders. So the 5 demands were basically to have one common redressal forum, because for policyholders there is IRDA and Ombudsman, for insurers and TPA there is the GIC and IRDA, but for service providers there is no common redressal forum. So we are focusing on this high-level tribunal to address our concerns. And you also need to understand the costing. So I've already exceeded my timing. I will not go into the details of the costing, but please ensure that you know your cost of service. And this is the cost for a specialist decided by our Nursing Home Board of Tamil Nadu. So we are incurring 623 to provide service to one patient at one point of time. So if you are giving less than that, so you are entitling loss for every patient. So ensure that you understand your cost of service provision and then charge accordingly. And this is the charge for a super specialist. And all these were based on International Patient Safety Code, IRDA norms for billing, and the clinical pathway given in our Clinical Establishment Act, as well as a lot of components have been added to this. So let me just fast forward it. And this is the last few slides, a warning from our costing accountant. Cross subsidy and under absorption of costs can lead to financial strain over a period of time. And if you continue to work below the cost, it will slowly push the hospitals into cash flow crisis and debt trap. Patient and practice safety is important, so you have to follow the standard of care and quality of services. Otherwise, you can have a lot of issues with reference to medico-legal challenges, because the insurers will not help you when there is a medico-legal challenge. And we are all compensating this cross-subsidy by overworking and incurring, having stress because of the long working hours. So it's high time we take care of our health as well and understand all these basic parameters. So cash flow issue will curtail financial freedom. Investment and growth will be delayed and denied. Working on non-sustainable rates in insurance or any schemes is not advisable. With more insurance penetration, you will not have out-of-pocket paying patients to compensate for insurance patients. So you have to understand this framework before really signing your MOU. So with this, so GIC planning for 100% cashless, is it feasible? If it is feasible, if there is all eligible hospitals across the country are empaneled, there is single portal empanelment, package should not be the mandatory clause, reimbursement should be there, and also there has to be a framework for negotiation as well as framework for highlighting our grievances. So thank you so much for your patient hearing, and over to you, Vardhaman. Thank you so much.
Thank you so much, sir. And I must say that this was definitely an eye-opener for all of us, and I'm sure for all members across Maharashtra and, of course, across the nation. And I think some of the issues that you have highlighted, I think they are something that are not only of urgent, but both urgent and important nature. And we have to all work together, as you have said, to come and progress together, work hard towards achieving what is our due right for us and for our patients as well. So before we go to the second talk, I would like to request our chairperson, Dr. Agarwal sir, for his quick comment, and then we'll go to the second talk, please.
A very informative talk. Thank you, Dr. Nirmal, for enlightening us in regards to the insurance system, how it works, what are our problems, how to deal with the problems. Thank you so much. We'll definitely come out with our guidelines and strategy to combat this issue. Thank you so much. Over to Vardhaman.
Thank you, President.
Thank you so much, sir. So I think with this background, we'll go to a very important talk by Dr. Hari, and he's going to talk to us about some of the things that you should all keep in mind when you're actually signing the MOU with your insurance companies and TPS. As we have said, Hari has done a lot of groundwork in this and is extremely meticulous, and we are all looking forward to his presentation. Over to you, Dr. Hari.
Thank you for the opportunity, sir. So, for me, as usual, I don't have a presentation today. I would rather keep it, conversational. And it's something like Dr. Nirmal has covered things, very much in detail. And he takes a lot of effort, and TNOS is doing wonders. Let me tell you that. I've been in touch with a lot of associations, a lot of groups, but compared to all of them, Dr. Nirmal is doing a fantastic job. I had a privilege of attending few of their meetings as an silent observer on the side, and I generally realize that I don't have anything else to add on. So the entire team is fantastic, sir. And yeah, so let's start with this thing, sir. See, now we have just discussed that why the insurance cashless, why the insurance industry is there, but let's look from not from top to down. Let's look from bottom to top. So, as an individual hospital, I'm a small hospital, single specialist, or one or two or three specialists running an eye hospital, doing around 30, 40, 50 cases in a month. So, why do I need cashless? Let's understand that part. So, as the time goes, in any healthcare service, there is different levels of service. It's something like any other consumer behavior. You can get a product for 100 rupees, the same product at a higher quality for 120 rupees, 150 rupees, 200 rupees. Now, the affordability of the patient is in question. Now, see, the moment a patient gets a cashless treatment option at a hospital, so what happens is the patient's purchase power increases in a lot of cases. A lot of cases increases because the patient's insurance in most of the cases is borne by his working kids or somebody else. So as Nirmal sir said, the payer and the utilizer is different. So the person who is utilizing the treatment just wants to get the treatment done without giving any amount. So they are more amenable to being willing for the surgeries. They are more amenable to going for whatever according to their packages. I had cases where patients came and they asked for the cheapest option. And when we inquired to the patient, what does your son do, your daughter do, then we realized that their kids are working in Amazon or Infosys, and asked them to send their insurance card. And it turned out that we could push the patients for a higher package. So that is one of the benefit of a cashless coverage in your own hospital. Now, second benefit is the more walk-in. See, nowadays what is happening is nobody is going to ask the neighbor that who is a good doctor. Everybody is going to switch on the app of their company and see which are the listed hospitals, and they'll directly walk into the hospital. Now, we might not even realize that how many patients we are missing just because we don't have the cashless for a particular insurance, because those patients might not come to you in the first place at all. They have already done the research. So they might not come to you in the first place. So you don't know what they're missing. Okay. Now, the thing is, as far as hospitals are concerned, all hospitals are business establishments. So whatever said and done, there is an essence of competition. Now, this essence of competition should be beyond the economics part of it, and it should more be in the quality of service part of it. So every hospital should be empaneled and should be empaneled at a decent rate, so that there is no competition in this rate part. It should not be like if you go to that hospital with my insurance, you get a imported monofocal covered, but in that hospital I can get only an Indian monofocal covered or something like that. So everybody needs cashless as far as the hospital is concerned. Now let's see, why does the insurance company needs cashless? Insurance company needs cashless because of few reasons. That the moment there is a cashless, we are giving them a credit time. The hospitals are at the receiving end where they can enforce their rates, their terms and conditions, because our money is stuck with them. So we are giving them an interest-free loan for the time being. That's first thing. Secondly, they can ask for discounts just to be on the network. So what is happening is insurance companies know that hospitals are desperate to get into the cashless network for the sake of a higher business, so that they will utilize as a bargain chip in order to get a better discounts and a lower rates. Okay, so that is there. Now, how does Dr. Nirmal has been very in detail about how the rate fixation, how much, what is scientific costing. But the thing is, the problem is, let's look at the other side. When you look at the insurance companies, their costing is far from scientific. Their costing is just law of averages and statistics. That's it. So you should realize that this one aspect is very important for us to, as an association, as practicing doctors, to understand, which is called as reasonable and customary. So you will find that a lot of cases when you send a claim, some deduction has happened mentioning that reasonable and customary, reasonable and customary. So this is one thing that we should understand, what is reasonable and customary. So in a specific geographic area, there is a specific, reasonable cost which the insurance companies arrive at, beyond which they will not pay the customer. So basically, like if the consultation fee for a ophthalmologist in a region is 500 rupees, 600 rupees, 1000 rupees maybe, and suddenly one patient is going to foot a bill of 2500 for consultation, then it is going to be deducted, quoting this reasonable and customary. Now, every insurance policy, whether it is every insurance company MOU, whether it is this MOU that we sign with the insurance company or the client who is buying the health insurance signs, this reasonable customary is always there. It is mentioned that the reimbursement or the payment will be done according to the reasonable and customary charges as prevailing. Now, what is happening is, we as a hospital, we are so desperate to get into this cashless network that we end up agreeing for lower rate and lower rate and lower rate. So what it does is, it reduces the average cost of a particular procedure in the geographic region. And after some time, we are not able to lift that rate up. The entire health inflation that we are talking about, I don't see where it is. Thing is, the cataract surgery cost is going down. The reason being that I am quoting 40, my next door neighbor is quoting 35, next door neighbor costs 30, then 20, 25. So what happens is, the average cost of claims, whether it is cashless or reimbursement, going to the insurance company over a period of time is reducing. So we need to build our rates, our average cost of a region. It's very easily done in smaller cities, smaller towns. Recently, I had a hospital who called up from some place in Maharashtra where they had done the same. There are only two hospitals which were in cashless. So both of them negotiated together at the same time, and they managed to get a very good rate because there was no other party in it. So you should understand this reasonable and customary, and you should stick to your cost. Now, what another thing we should understand is, what are discounts and when are they applicable? Okay. Ophthalmology as a branch, 99.9% of cases can be put into packages. That is, there is a predictable cycle, there is a predictable workflow. So that entire fact is utilized in making our treatment rates into packages. So here what is happening is, we are going into package rates. One thing that we should understand is, when we offer a package rate in a tariff agreement to an insurance company, we have already accorded them discount. So when it is packaged, that means the entire thing has been packaged into a single billing product and it is already a discounted rate. So whenever you sign an agreement, in the discount clause, never include packages in the discount inclusions. So always be sure that when you sign an MOU or an agreement, your discounts should exclude packages. Okay. Now, discounts is something that insurance company is going to ask you. Why are they going to ask you? Is because they have a feeling. I would say it's purely a feeling. The reason being that most of our cases being packages, discounts don't apply. But they have a feeling that the moment we go into an open billing and since they are giving us a cashless service, because of cashless we are getting more patients, we are obliged to give them a discount on our rates. So that rate discount is started at 5%, 10%. Now they have the audacity to ask for up to 20%. But realize that this discount is your choice. You can deny it. If it's just a pure business bargain. Like you ask for a discount, they say no, not enough. You offer a discount, they say not enough. You say, okay, I cannot give you more than that. The discussion should not go further. We should not show a desperation when you're negotiating with an insurance company. Now, first of all, we should have that power to say no. Okay. Now, how does the power to say no come? Is when your own practice has got patients who are walking in, irrespective of whether you have a cashless coverage or not. Now, why does that happen? Is purely by your work. So, now what happens is when you do a lot of cases on reimbursement, it is a financial loss to the insurance company. They will come to the terms. But the negotiation for rate, you will get an upper hand only when you have a good number of patients who are going for reimbursement. If you don't have that numbers, if you don't have that kind of a clientele to do it, then it is going to be very much difficult to negotiate. So when you negotiate, it is just like a open market negotiation where you feel that the rate is not suitable to you or the rate is not workable. Kindly say no and have the willingness to walk back. The power of saying no in a negotiation is very important. Now, many people ask me if we say no and they say, okay, no, then what do we do about? There are many ways. First of all, if you have a good patient following, that patient, irrespective of what, whether there is cashless or reimbursement, is going to help. Is going to come to you. Secondly, your hospital staff should be clued up with reimbursement methods, the form filling and everything. You can give them a complete assistance at your hospital. Third, there are few like there's a company called B Assist, which is doing business in Bangalore and here. So these companies are what I call as pseudo cashless. So what they do is they work as a middleman where they foot the bill of the hospital and take your bills for reimbursement for the patient. And when that money comes to patient's account, this company will take that money from the patient. So this is also one viable way in which you can do. So these are stopgap arrangements till the time you get an empanelment. But the thing is, the more you say, the more desperation we show that we need to get empaneled, we need to give cashless services, lower the rate that you will get. Okay. Now, the thing is, we should always work with our colleagues. We should not see our colleagues as, cutthroat competitions. We should be able to work with them in a locality. Your and their rate should be matched. It should be comparable. I'm not saying exactly same, but yes, it should be comparable when it comes to the insurance industry. The reason being that the insurance company will always try to push the patients to the place with a lower rate because they want a lesser claim outgo. Okay, so this is the thing about insurance companies. Now, there are a few more things like understand that reasonable and customary clause whenever is applied. For example, in let's set aside package cases. Let's take one particular case called DCR, diagnostic rhinostomy. So there is a I normally do it around 55,000 in open billing, 10% discount. They apply 45,000 is the payout. So what happens is many a times these TPS will come back saying that revise your bill. So I normally reply to them that show me the clause under which the revision is sought. And immediately after that, what we see is that the full approval comes. See, the thing is, the TPA does not have a wherewithal to reduce your surgeon fee, your OT charges, because these are non-contestable charges, but within the reasonable thing. So, thing is, you should always be very stern in your communication. It should not be like we are trying to justify ourselves. Understand, as far as the insurance company is concerned, they don't bother whether you have a Zeiss Numera T microscope or a Centurion or a Constellation machine, or you have an Appa or a Chakshu. So the thing is, what they are on is the cost, and cost which is comparable in that locality. So that is how the negotiation with insurance companies works. So in short, if you are going to go for an MOU with an insurance company for cashless, be sure don't agree for a lower rate. Secondly, understand what is the reasonable and customary charges of your locality and do your level best as a member of that locality to increase it over a period of time. Don't show a desperation for cashless, and always be ready to say no. And in case you still have insurance cases that you need to handle, you can use services of NBFCs for bridging the time gap and still do cases. Now, few more things which I would like to say is, whenever you sign an agreement with an insurance company, please look at the tariff wordings very carefully. So I'll give you one example. I'll compare two tariff wordings. Okay, just hear this out. So cataract, MICS, including lens cost up to 7,000 is 25,000. Okay, this is one tariff wording. There is another tariff wording which says MICS, cataract, all kinds of implant, 35,000. So out of this, which is a better tariff rate? At the outset, you will feel that the 35,000 is a better tariff rate. No, what has happened is they have, just by not mentioning the implant cost or the specification of the implant, they have locked you into all types of implant in a single tariff. So even if you send a claim for PanOptics tomorrow, they are going to give you only 35,000. Okay. So whenever you sign an MOU, you have to look at the tariff wordings very carefully. They are very important. So most of the times when I get hospitals which contact me for billing issues, first thing I ask them is, kindly send me the tariff document as it is, because those wordings are very important. They play with words because it's a legal document, and as doctors we are not used to it. Kindly take a pen and paper, read it, and if you don't agree, please ask them to revise. Never show a desperation to empanel, never show a desperation to take cashless. You should have that bargaining chip with you that you can play with. So just about it, I think we are already at 9:30 here. And Vardhaman sir,
Yes. Sure. Thank you so much, Dr. Hari. I think definitely it was a very lucid discussion about all these aspects, and I am sure that all our members would have gained a lot of insight into how they can go about having an MOU. So before going into the discussion, I would like to now invite our co-host, Dr. Atul Kadane, who is the Honorary Secretary of Maharashtra Ophthalmological Society. And I would like to request him to kindly introduce our panelists, and then we can start the discussion with our speakers and with our panelists again. Thank you.
Thank you, Vardhaman. Good evening, all respected MOS members. Today we have in panelists Dr. Anand Deshpande sir from Aurangabad, Dr. Mandar Paranspe, our treasurer Mos from Pune. Then we have Dr. Manish Bapaya from Nashik and Dr. Vinay Nangia from Nagpur. So I'm sure a lot of you have a lot of questions to ask, and panelists will be a mediator for us to start the discussion. So over to the maybe I say A. Deshpande sir to start the discussion.
Yeah, from all this discussion, one thing is very revealing, that all doctors of that locality should come together and decide and the prices, and then write the MOU, sign the MOU. Secondly, all associations should come together. So coming together of the ophthalmologists of the locality and coming of the associations together will cause the pressure on the TPA, and then they can be molded like anything. So this is the main theme of that, because the individual competition, because of the individual things that is going on, all these things. Secondly, as Dr. Nirmal said, and Hari Krishnan also said, that capping is the main thing. It is not that the capping is main thing. What is required is, as other departments, that is surgical or medicine, they whenever admit, if the surgical procedure is there, so their charges are no fixed. They can cover the amount from admitting in the wards, admitting in the ICUs, and so they can balance all the things, and that is acceptable by the insurance companies. We being a daycare center, it is not possible for us. So our unity is more important, and on that, what Nirmal says or Harish says, his opinion. Yes.
Sir, we all need to come together. That is there. So at least TNOA has started something. Let's keep the fire going, and I think it's high time that we all take it forward everywhere.
Yeah.
Can I add something here, sir? So basically, right now, the issues why they have come to, I mean, there are lots of issues with insurance companies which need to be tackled. The thing, what is this 100% cashless, desire on part of with the authorities? Why it is dangerous is that because it is going to create a lot of problems between patients and us. Because if, for example, if a patient says that I have for cataract surgery, I have package of 45,000 or 50,000, and there is a package of 24,000, and the insurance company is going to say that you can only put 24,000. I mean, the lens.
This is 24.
So they are trying to save on whatever 26,000 is there, but the patient is going to demand higher. Higher lens or higher package because he feels it is rightfully so of his, and since there is a person who's staying behind the computer screen, the insurance person, they are going to have problems with the doctor who is sitting in front of them. So this needs to be conveyed to the consumer forums that look, this is what is going to happen going forward. This is not in the best interest of the consumers, and this is going to cause problems for patient doctor relationships. So these are the things I think. So we need to have consumer bodies also on board on our as our partners in in fighting this menace. I think.
Yeah.
Can I put in something, or Dr. Nirmal, would you like to answer back, or can I say something?
Please go ahead, sir.
Yeah. So it's generally what we're seeing, and it's very hard for an individual to negotiate, and sometimes I feel that it's even quite hard for doctors to get together and sit down, because it requires a different kind of expertise. It's a kind of administrative expertise that you require. And to me, what it looks like is that I'm very glad that MOS is joining up gradually with Tamil Nadu. And one of the suggestions I'd like to make to the MOS is whether henceforth could we do this jointly, actually, so that the letters read the same, the rates read roughly the same, that we're negotiating on the same pattern, so that at least they come to know that two states are together. And I'm sure that word will get around and other states will start joining in, actually. And then the other thing was that the signing of MOUs that I think Dr. Hari mentioned, even that is quite complicated. When you get a 30-page document that is different from each this thing, to think of going through, you just have this urge to just sign and send it back and get on with your work. And so maybe one of the things that could be done is that you try to get a uniform MOU, actually. That doesn't matter which TPA it is, doesn't matter what insurance company, but the TPA, but the MOU becomes regular with the same wordings, so that it's been vetted by all the state organizations that are involved in this. And the third important thing was that, for which maybe there should not be any debate, is that when you set up you mentioned about a cost accountant, and if you could get the insurance companies to agree to involving a cost accountant, so maybe a cost accountant from their side and our side, if they are at all willing for it, then maybe things will just come out. And this thing about they're not doing a rate analysis, which I've had, at least 5 discussions with several senior people in Nagpur, and they don't know even the meaning of vitrectomy. They don't know anything, actually. They've not done a rate analysis at all. So what Dr. Hari said and what you said, that it's all statistics based on how much money they would like to make to, to have the insurance company run. So, these are the things that I had in mind. And, maybe all of you could sort of give your inputs regarding these ideas.
Thank you, Dr. Namgia. That was wonderful insights. We would definitely like Maharashtra Society to join us. So it is not one society fighting; it's for the fraternity of entire eye care providers. Because when insurance companies decide or talk with us, so they don't segregate on the basis of region or locality or city. So decision is going to be copied by the other insurance providers, and they're going to implement it across the country. So it's always better we all work together because it is a common objective, and it is in the best interest of our profession and particularly our specialty. Because as Dr. Deshpande sir said, so ours is unique. Daycare and our hospitalization hours is hardly few hours, and that brings in actually a lot of complexity, because within that 3 hours 4 hours you have to do the entire admission discharge process. So we have to be really doubly efficient to do that, and dealing with the insurance companies can be time consuming. So that actually there's a lot of wastage on this front. And second thing you mentioned about using the same template and formats. Definitely, I've already shared the our documents and memorandum with the insurance companies to Dr. Santosh and I think Vardhaman also. So you can use the same wordings. The basic thing is we have done use the same memorandum for the National Health Insurance Summit as well as TNOA, as well as we've shared the document with the Private Health Association and Nursing Home Association across the country, as well as Hospital Board of India. So which means if we all share the same wording, same formats, the insurance companies will know that it is coming from a common forum, right? So they all know what is happening. So if all the states join together and if AOAs help us, we can definitely make an impact.
I would like to add something. First of all, I would like to congratulate Professor Dr. Nirmal Frederick sir for his pioneering efforts in getting the insurance issue right in the center of our discussion and bringing the right perspective to this problem. This is a multi-pronged problem. This is not something which is going to be solved very soon. And I think we need very concerted long-term efforts from multiple agencies, multiple associations. And as of now, what I can see or I can read in the situation is the insurance companies are typically using the tactic of divide and rule to their advantage. And unfortunately, many of our colleagues are falling prey to it. Like Dr. Hari said, that this fear factor of FOMO, what is called in modern day language, that fear of missing out, that is what is actually playing on the minds of many of the colleagues, particularly the younger colleagues who have just started practice, who have invested a considerable amount of money. And obviously, they are looking at recovery. So they agree to many to very low rates, and that changes tips the balance against negotiating for better rates. So I think the first thing associations like us, the Maharashtra Ophthalmic or Tamil Nadu, should do is to try to sensitize the younger colleagues amongst us. Tell them that they are not going to miss out on anything, even if they don't sign on the dotted line. And once we have a considerable mass support from our own fraternity, probably that will help us in fighting this cause. It is a long battle. It is not something which is going to be over in 1 year, or maybe it might take few more years. So, but at least I must congratulate Dr. Santosh Agarwal for taking this first step and holding this webinar right at the beginning of his tenure. Because these are some issues which all of us are facing, and it's going to be a big problem going forward.
Any other comments by our panelists or any queries that they would like to ask the speakers?
Yeah, I would go even one step further, that just to catch up with what Tamil Nadu Ophthalmic Association has done, maybe we may send similar letters, and then when we have done all that, the future letters, if that sounds all right to everyone, can be jointly signed actually, so that we don't need to pretend that states are acting independently. We need to actually, as Dr. Nirmal said, really tell them that we're acting together. So I think that is perhaps something that you may consider.
Yeah, I think that's a great suggestion, Dr. Nangia sir. And I think both the presidents being here, TNOA as well as MOS, I think this seems to be, definitely a great solution to give a head start to even other states, because they will also get involved probably with this kind of initiative.
Also, I want to ask Nirmal sir, have you tried for other states and also to AIS, our parent body, and IMA also? Have you tried? What is the response from them?
Okay.
And
Let me clarify a few things. So I just took over as president TNOA a few months back. So to be precise, in August. So then we had to formulate our insurance committee and bring all the stakeholders of Tamil Nadu together. So that itself is a big task. So we thankfully we achieved that. So we were able to have an insurance committee, which was a representative of all the major stakeholders like Arvind Eye Care System, Agarwal Eye Hospitals, then representative from the private sector as well as from the government sector. So there is a huge amount of support from Tamil Nadu. So, and we did had the first meeting at Shankar Netralaya, and then followed by a few Zoom meetings to discuss the rates as well as discuss the strategies. So this took really considerable time within Tamil Nadu to get to this state. And in addition, we have also had to work with the IMA, Indian Medical Association Tamil Nadu. Since I am part of both the organization at the leadership level, it was easier as well as a bit complex because IMA, you all know, is a national organization, and we did involve in many discussions like the National Health Insurance Summit, and recently GIC, Gender Insurance Council, called us for a meeting to discuss and take our inputs also. So we have represented both at the state level and the national level our concern, particularly from the ophthalmic fraternity. Even 2 days back, we had a press meeting at Chennai telling what are the problems related to this 100% cashless, basically to reach out to the public as well as to the, as Dr. Nange said, the consumer agencies. Right, so now they are also in touch. So it took really considerable time and effort. So AOS definitely, yes, they have also, AOS have formed a TPA committee. I'm sure they will join us. And if Maharashtra and we join together, definitely the other big state societies, so a lot of inquiries from the other state societies also, we can make this as a movement. Not because I'm some against insurance companies or TPAs. Basically, as a quality professional, we don't want the quality of eye care to go down because of the cost concerns. That is my primary motive in taking up this initiative.
I have been interacting with a lot of associations, state level, city level, district level, whichever level, sir, I have interacted with. Now, one of the biggest hurdles which I see among our associations is our associations don't identify the fact that we need to work for things beyond academics. So most of the associations work, Mani sir, we had this discussion before also. So we are too busy in conducting academics, whereas academics is not the job of the association. That's, well, maybe one of the jobs, I understand, but it is not the primary job of the association. The association is supposed to protect the profession, and that realization slowly, it is picking up. I can tell you that, because in recent times, you will see more issues being handled by the association, and we will see more surgical videos being popular on YouTube. So it's the time that we stand together and defend for our future bread,
Now, world over, all these policy issues and advocacy issues are led by the associations. Like you take the American system, the entire insurance industry and the healthcare industry is being represented by the American Medical Association. So this thing is a debate or challenge or the conflict is between the insurance companies and American Medical Association is well known, right? So it's been going on for 30, 40 years now. The same tactics, I was discussing with some of my friends at in the US, the same tactics what they followed in US, they are following in India now. So they've been successful, or rather, we all know that American healthcare system is a big failure, particularly on the insurance aspect, and elections are run and fought because of these issues. But unlike in US or European countries where health is a major subject, in India it is not a major health subject, and so it will soon take up as a major policy issue from the governance side. But from our side, basically to protect the interest of our youngsters, if you all see that ophthalmology is not being taken by the top 1,000 or 1,500 rank holders, which means the interest in the profession or the specialty is going down. So as seniors professional, it is our duty to encourage our youngsters to take up the specialty. For that, we have to safeguard our interests. Otherwise, over a period of time, even our son or daughter will not come to our profession.
I think this coming together is rather should be done on rather emergent basis because of the new things that they have come out with. Trying to force too many things down our throats. We need to understand the enormity of the situation, because even today on YouTube, I was just checking hardly 35 people, 40 people. If it was a cataract webinar, I'm sure there would have been lot more. So there has to be awareness among the people of our fraternity, as well as among the consumers, because it's ultimately the two parties are going to be affected most. So this, if you have to take from patient whether you have insurance or not. Yes, whether now even if you are not empaneled with a company, and you have to take that undertaking from patient, why should anybody do it? Because the patient is going to go for reimbursement. They are going to say that these are the rates. If the patient has given that he doesn't have insurance because he wants to do at a package that he wants, then the same insurance company is going to tell them, you have said no, so we won't pay you. It's going to cause a lot of problems among us and the patients. That's a dangerous thing to just accept.
I agree with what you're saying, that the challenge really, I'm not surprised that there are very few people attending this, because, most people haven't really figured out what the insurance companies are doing to them actually. So that will take some time. I think therein lies the importance of setting up the state, insurance sort of group to sort of take this forward. And in time, as what will happen is that you will have details of the people who have actually, signed MOUs, become a part of the PPN or aspire to do that. And then you will have this group that you will be able to communicate with much better, actually. So that's what our group will be able to do gradually, because that's what I said, that it's very hard to bring doctors in one city to, for this cause. And therefore, it must be extremely difficult to bring doctors in the whole state, to be engaged in something like this. But I think that gradually that can happen with the state, insurance group sort of taking the lead actually. So Santosh really has got a lot of work to do now.
So the one way forward for this is that now we obviously this has to be decentralized, in the sense that we need to contact district associations. We have district associations in almost all the districts. So we have a president, secretary in almost all the local associations. So I think they need to be taken on board. And like Nangya sir said, we need to formulate a letter on the same lines of TNOA, mentioning what are the key issues. In fact, Dr. Manish had drafted that letter, which was circulated to MOS immediately after the conference. And I think we need to send it again and again and try to get the associations, the district associations involved in this issue in a big way, because they are the ones who can probably contact their members and appraise them of the situation, make them aware, and give them. It's like giving a helping hand. It can't be done from the top. It has to come from the bottom, and it will take some time. But I think if we start the process now, in a few months' time, we will see the results.
Also, one of the important things that Dr. Nirmal mentioned was that, this is not something that we're trying to keep for ourselves. We're actually trying to say that everyone who is registered as a hospital or as a daycare center should be a part of the insurance, which will increase business for everyone. So I think that awareness can also sort of go to the individual members of the society, and maybe people who never thought of insurance will think about it once they have the guidance, and that will only increase your leverage in this matter, actually.
So I have a question for Dr. Nirmal sir. So what have you done? You mentioned that there are some consumer bodies are there on your forum. So in what way have they been contacted and they have been gotten on board?
So one is we have circulated why this policy of 100% cashless is against patient interest. So 5 points we have shared with all the consumer groups, the Lions Club and the social organizations. So we got in touch with few social activists, told them if it is 100% cashless, yes, it does look beneficial on the superficial thing. But if you approach or take the golden hour concept, right? So within 60 hours, your care has to be started. The moment you reach the hospital, care has to be started. If they're going to get in touch with the insurance companies with your card, and they're going to wait for authorization or some prior approval, right? So the care process will not be done. So either be a diagnostic evaluation or imaging or the management part. So we are going to lose a significant amount of time looking for authorization. So acute care will suffer. Second, that is not in the patient interest. Second is the choice of providers, right? So when you are in an emergency, your neighboring hospital, if it is not approved or not in the cashless panel, so you have to go and search. So for example, if you are in AMI, so we gave this scenario. If you have a chest pain, and so you'll automatically will go to the nearest hospital available and nearest ambulance, and not to the hospital. You will not be searching in the Google for your empaneled hospital or your medically proven hospital, right? So this brings in that kind of emotional connect with the consumers. The second is the complexity it has got. So the costing process, the non-transparent things, particularly deductible, because most of them have suffered with co-pays and deductibles. So we give them the examples that this patient received only 30 to 40% of what is eligible in tune to their sum insured. If they have gone for reimbursement, they would have got 90% of it. So these are things we have encouraged our and reach out to them. So even in the press meet, we highlighted these 4 important things. One is acute care. Second is the choice and right of the patient to decide their care provider or the doctor. And third is the pathetic package rate, which in fact every individual with insurance loses over a period of time. And fourth is the grievance mechanism. So it is not actually functional. Even though there is grievance mechanism within the TPA and insurance framework, so there are a lot of RTI in question. So when we ask the consumer association to file RTA about how much reimbursement they have given, how much cashless they have given, how much incentivization they have given to NABH accredited hospital, there is no response. So all these RTA queries have been pending for more than 6 to 9 months. So which means there is no response or no data from them. right? So we have highlighted all these things with the local forums. I think it has to reach out to the pan-India consumer society also.
Yes, sir. So I had approached the consumer forum in charge in our city, and he has given the contact number of consumer forum in charge for Maharashtra, and has forwarded the issue to them. So I'm sure our president sir will take initiative on that, and because uh, I think it's very important that we have patients on our side in this in this you know thing. Yes, sir.
Yeah, thank you, Nirmal sir and Hari sir and all the panelists. I think we had a very good discussion. To summarize few things, just one word is we have to be united. That is very important. All district societies, as Mandar has already said, all district societies we have to come together. All state societies, our parent society, AIS, IMA, everybody has to come together. It will take time, but definitely we will head towards it. Then second is we should have some minimum rates. We should not curtail down our rates, or we should not accept the rates which are laid down by the companies. Third thing is redressal forum. There should be a redressal forum from insurance side. What Dr. Hari has said, we should be able to say no to the insurance company. That power, it is very difficult to come in our members, but we have to gather that power. Then don't agree to the lower tariffs. That is very important message has been given. There should not be any desperation to agree to every term and condition of insurance company. And second is the MOU should be read very meticulously. Each and every print, small prints also you should give attention. And then what Dr. Nangia has said, we should have one MOU. So there should not every time we are not able to read every MOU, 30 pages MOU. So we should have one MOU. And we'll definitely have the letters similar to Tamil Nadu, and we'll send to the companies. And also, we have to make the patient aware about the bad effects of 100% insurance, what Dr. Nirmal already said. So, patient awareness, our doctor awareness, and also we have to make the insurance companies aware, and also government. So, all these four things we have to take into account, and we'll definitely try to solve this issue. It will take time, but with all your support, I think we can head towards the solution, amicable solution. Thank you so much. Over to Vardhaman, please.
Yes, thank you, sir, for your very nice summary, and also to the for the concluding remarks for this webinar. And I think this has been the need of time. And thanks to our president, Dr. Santosh Agarwal, sir, who has taken the initiative to form this insurance committee and also to initiate this discussion about the challenges, and also to guide us to start this webinar. Uh, Definitely, I think today's webinar has been a great insight for each and everyone. We have understood both the challenges, and we have also understood what can be possible solutions also for the same. So basically, before we go to the official vote of thanks by our honorary secretary, I would like to request Dr. Agarwal sir to unveil the new initiative of MOS, which is basically the special video which has been created to create awareness about the firecracker injuries. We all are on the eve of Diwali today. And this is initiative by our president, Dr. Agarwal sir. And I think this is the need of time, as we all know that last year, by the scientific committee of MOS, we had done one study which was pan Maharashtra, and we had seen that more than 460 or 70 patients were actually injured during the Diwali firecracker eye injury survey. And this is very important for us to know, and to also propagate to our patients what should be the preventive measures. So over to you, Dr. Agarwal sir, to kindly unveil the video of this good initiative.
The screen.
Yes, sir. Yes, sir. We can see the screen.
Yes.
Can you see?
Sir, we can see the, I think the list of
Template.
Video.
templates. Yeah,
Yeah.
but I think you may have to click, double click.
Double click.
Double click.
Is it okay?
No, sir.
No, sir. Can you see the video on your screen, sir?
Then in that
video
case,
is not running.
Yeah, correct.
Just try and
You are
click.
not able to see?
No, we can see your mouse somewhere else. Get the mouse on the video movies and click twice if you can once, and then I think it'll work.
or maybe you can try the another version. There are Marathi, Hindi, and English version. No? Maybe that particular video is having problem. Shift to another video and double click it.
Okay.
You can even start the video, double click the video before you actually share the screen. Even that's possible, actually. See if that works better, and then you can share the video movie, actually.
Sir, or try to click, do the right click on that video so that it can give you options for different softwares to open the video.
Maybe the software required is not.
Can you see now?
No.
No, sir.
Not able
You can
to
only
see?
see the thumbnails.
Right. We can see the thumbnails of the 4 options. There is Marathi, I think 2 English and 1 Hindi.
Okay. That option. You are not able to see the video.
No, sir.
I think you start the video, stop sharing, start the video.
Correct.
And then share the screen.
Share the video, actually.
1 minute, sir. Stop sharing.
Yes.
Now I have to open it first.
Sir, I think you have not stopped sharing yet. It is still, your screen is still
visible to us.
Stop share.
Yes.
Now it is stopped.
So I have to
just open the video.
Go to the screen first.
Go to the same thumbnail, start the video, and then go to screen share.
Something is wrong, I think.
It's okay, sir.
Okay. Sorry, but I have.
No problem. So you can probably explain what this video is about, and maybe we can put it on our official groups. Yeah.
Yeah. I will stop sharing first.
Right.
Yeah, these just firecracker injuries. We have highlighted how to this firecracker should be lighted actually, and what precautions you should take during your firecracker, and what injuries that can happen to the eyes, and how to curtail down these injuries. I will send you on WhatsApp. Definitely.
Yes. Thank you, sir. I think it is definitely a much needed initiative at this point when we are on the eve of Diwali. And congratulations to you for creating this video series also.
Thank you.
Yes. So I would like to now invite our Honorary Secretary, Dr. Atul Kadani, to officially give the vote of thanks, please.
Thank you, Vardhaman. To all MOS members, we have a very nice informative webinar. One thing I can say, it's just the beginning. The famous Hindi dialogue, picture abhi baki hai mere dost. So let's be together. And Nirmal sir, thank you very much for joining us. But we are not going to leave for one webinar. We are going to trouble you more and more afterwards. Dr. Major Hari Krishnan sir, you also given very nice input on all the various issues of the TPAs and insurance companies. Thank you all panelists for, we'll have a nice discussion. Thank you, Entod. Thank you, MOS members. And thank you, Vardhaman, for having a very nice show here. Thank you,
Yes.
everyone.
Thank you very much, and wishing everybody a very happy Diwali.
Happy Diwali. Yeah.
Happy Diwali.
Thank you all. Happy
Everybody.
Diwali.
Happy Diwali, everyone.
Happy Diwali, sir.
Thank you.
Thank
Good
you.
night.
Good night.
Good night.
Bye.
Good night.
Good night. Good night, everyone.
Night.
Good night. Happy Diwali all.